Welcome to The Exam Room with your host, Dr. Rhiannon Winsor. In this podcast, we explore how value-based care is transforming healthcare for the better. From probing today's challenges to charting innovative breakthroughs, we're here to dissect what's shaping the future of patient-centered healthcare. In this episode, we sit down with Dr. Darlene Melk, Chief Medical Officer at Chiricahua Community Health Centers in Douglas, Arizona, and Dr. Shantipriya Siripurapu, Medical Director for ABC Network, for a deep dive into what it means to move beyond simply checking boxes and instead focus on delivering meaningful outcomes for patients. Together with host Dr. Rhiannon Winsor, they explore the evolution from task-based care to proactive, prevention-driven models, and how that shift intersects with payment reform, team-based care, and the realities of rural medicine. From rethinking incentives to reworking communication systems and using data more effectively, this conversation challenges us to rethink how we define success in the exam room.
So we're back in the exam room today to talk about shifting beyond task completion. And I am joined by two lovely ladies, Dr. Siri, who is the Medical Director for ABC Network, and Dr. Darlene Melk. She is the Chief Medical Officer at Chiricahua Community Health Centers in Douglas, Arizona. How did you get the role that you currently have?
So I joined Chiricahua Community Health Centers in 2010 as a community pediatrician and honestly didn't have any aspirations of getting into leadership. But our service area is very, very rural. We are southeastern Arizona, where there is definitely a health professional shortage. And not just a shortage of providers, but shortage of leaders. And so in about 2015, I took my first leadership role over our mobile medical clinic program. And then in 2018, I became a director of community medicine as we recognized there just needed to be more physician leaders in our organization. And then in 2020, a few months after the pandemic started, I took my role as chief medical officer because at that time, our CEO was also the chief medical officer. It was dual roles for several years, and it was just becoming impossible. And so I applied and was accepted to take on this role, and it's been a journey for sure.
So I'm hearing that there's definitely a need for it. What makes you feel passionate about it?
One of the things you recognize that if you want to make changes, if you want your voice to be heard, and to have some authority, it requires stepping into leadership. And so I'm passionate about trying to make our clinic better and make the experience for our clinicians better, the patients that we serve who definitely need us. And so that's my biggest driver is doing that.
That's awesome. Well, thank you both for being here with us today. So when we talk about shifting from task completion to achieving meaningful patient outcomes, what does that mean to health centers? What does that mean to each of you personally?
Well, for me, task completion, when I think about that, I think about taking care of something very quick and short. It might be just refilling a medication or a patient who comes in who's sick. And so I'm just addressing the immediate concern. But to have a meaningful patient outcome, I really, really strongly believe, this is kind of my latest messaging that I'm trying to push out, is we need to become prevention specialists. And so I believe firmly in the annual preventive visit for every human being, every patient that we see, from children, and obviously children under 3 we see more frequently than annually. But especially as we get older, that one visit is the time that we can take a step back and look at the whole patient, top to bottom. What vaccines are they due for? What cancer screenings, labs? And then, not miss those very important preventive services. Because I feel that when we get stuck, and this unfortunately happens, patients come to us just when they're sick and then they don't come back for their prevention visit, and then we miss something that could have been life-changing. So that's the shift for me. That's what that means.
If you ask me as a medical director for the ABC network, I would say my task completion or overall making a meaningful change kind of merges into one and the same. Because for me, when I am given a task or if I think I have to complete a task, it would mostly mean communicating to the providers and the medical directors at these FQHCs to see where they stand as far as their goals are concerned for meeting the quality measures. And of course, this all trickles down to basically taking care of the patient individually. So I want to make sure I'm able to approach the medical directors who can then communicate to the individual providers at the FQHCs to let them know what they need to do to meet these quality measures, which, like Dr. Melk said, starts from an annual wellness visit for them. But for the medical directors to understand that they are the ones who are my communication link to their team is what makes it important for me to pass them along this message that they can then finally pass it on to the individual providers and their teams. And we do have team members from each of these FQHCs who attend these meetings too. So that is a valuable addition because these people are very smart and they do understand where they stand and what they can do or how they can contribute to the final goal of achieving these targets.
And that team approach is so important. So you mentioned quality metrics, so that's a good segue into kind of looking at this through the lens of Medicaid and MSSP, because our health centers are part of an accountable care organization, and so that's where those quality metrics come in. So anything to add as far as the context of Medicaid and the Medicare Shared Savings Program?
So a lot of these quality measures are same on both the sides of business, Medicaid as well as Medicare, and we have Medicare Advantage too that kind of strive to achieve these same quality measures. The ultimate goal is the same. When we talk about these quality measures that CMS has set up for Medicare population, they're talking about screening these patients for depression, making sure their diabetes is under control, making sure their blood pressure is under control, making sure they are doing their mammograms or colonoscopy, and ultimately that leads to better care of the patient, because if they are not getting their mammograms, they're not getting their colonoscopies, these are the patients who end up having cancer and lead to higher cost of care. So that is the whole point of making these measures as something that the teams have to approach and look at the quality, the care gaps that they have to fill in. And hopefully they understand that this year, actually, with MSSP measures being similar to the same quality measures that Medicaid line of business has, it makes it easier for the team to approach the whole population together.
Honestly, I've been waiting for this shift to happen, and it's still kind of evolving. The shift away from fee-for-service and more towards pay-for-performance and quality. I mean, I feel, again, very passionate about prevention. And as, federally qualified health centers in this country who serve over 32 million patients, majority of whom are on Medicaid or Medicare, I do think that this kind of sets us up for success in this model when we do get maybe fully compensated for our performance rather than just the visits. And so it's an awkward space we're in because we're, caught in between both models, but it is best for our patients. Ultimately, I mean, we don't want our patients to be in the hospital. We don't want them to end up with cancer, advanced cancer. It is just good medicine to do all this prevention up front. And it's far cheaper or less expensive to the system if we can catch things early. So again, I fully and all of our leaders truly believe in shifting our minds towards this form of care. But again, it's a balancing act because we still are very dependent on fee-for-service.
Yeah, for sure. And so task completion, is it getting us there, or what else do we need to do?
Well, I think there are sort of three things that I think that we struggle with, at least at our health center, on our path towards, paying for performance and focusing fully on quality. So I mentioned one is that we're still very dependent on fee-for-service. And so what that has meant actually at our health center, then rather than having more time with your patient, our clinicians have less. to the tune of 15 minutes. And that's just really difficult to address everything in that visit. And so the reliance on our team is just going to become more and more important. When I say team, I mean medical assistants, I mean nurses, nurse care managers, care coordinators, others that can catch these gaps and help us close them. The other thing that I think is sometimes challenging is access to real-time data. And so our patients, we know, seek services outside of the health center, but we often don't know that until it's late in the game. And so having access to that, it would be really helpful and helping us towards that goal of, really focusing in on quality and seeing the whole person. The mention of using our team, that is also a challenge because teams cost money. They're an investment. They need to be paid every week. And unfortunately, some of the quality payments come so late that we can't really budget for that long-term goal. And so we are trying to look for ways to generate revenue from the services that the nurses or even medical assistants are doing, sort of to help us, overcome that challenge of the finances.
So, like you said, a balancing act.
That's a very important point that you made, Dr. Melk, because I know it is very hard in these times with the reimbursement rates going down every year and the cost of living going high. So it's important to keep that balance as to we have to keep paying our staff and then trying to make the money here to pay all these expenses that any office or any FQHC encounters, right? And yes, CMS has come with newer plans like I'm not sure if you have heard about the Advanced Primary Care Management. That is a service that any of your staff can provide, which is similar to the CCM, but a little different in the sense you don't have to have a qualified nurse to do that. APCM can be done by a medical assistant. It doesn't need that 20 minutes time, and the patient might feel more comfortable that the call is coming from the clinic itself because they are identifying as being the staff at the clinic. And these medical assistants or whoever is calling the patient is also aware of the patient's chronic conditions, so they are able to address their ongoing problems at that time when they do call these patients. So that is paying a lot from what I heard, anywhere from $50 to $80 per call per month. So that is a good way to earn that extra money. And again, it's not just for the sake of bridging that gap in compensation that this call helps. This call also helps in identifying any acute ongoing problems that we can identify and hopefully curb it at right time to prevent that hospital admission or ER presentation. And I totally get your point of saying, I wish I knew where my patient is going, like maybe have a Life 360 app on all these patients that, this patient is going to the ER, let's see what we can do to avoid that. But yeah, it is not always possible to have that. But we do have this health information exchange that a lot of our FQHCs are using, and hopefully that is bridging the gap of at least letting them know as to, hey, this patient is in the hospital or in the ER or got discharged from the hospital or ER. So the team members can call them and make that follow-up appointment in right time to prevent another admission or ER admission. So hopefully, these data as they trickle in can help bridge that gap, and our team here at ABC also can help you in certain ways. Kim Gonzalez on our team is working on getting those data together where she can give your teams the care gaps on diabetes control or blood pressure control or breast cancer screening or colonoscopy screening. So we can give those data to your team on a monthly basis, and then your quality team can work on it and see who is due for a particular screening or A1C check or whatever it is. So yeah, teamwork here too, bridging that gap in whichever way possible. And another thing I wanted to mention, I have mentioned this in the past too, it may not always be possible, but we just have to keep this in mind that the individual providers are the one who are taking care of these patients. So they need to be on board with ACO programs. They need to understand what these quality measures mean. So to educate them in any way possible as to what the quality measures are is important, and to incentivize them. I know it is not always possible to incentivize them again because of the gap and when we are doing this and when we get the money actually from CMS, and that too always remains to be seen whether we can make that money or not. But a promise to them that, hey, these are the quality measures, these many patients are assigned to you who have diabetes as their chronic condition, and if you control their A1Cs up to this percentage, this is the incentive that you get. So I think that kind of incentive, if the physician or the provider is aware of, maybe they will take that extra step to make sure that this patient makes a follow-up for their A1C control or their blood pressure control if they are not controlled. So I think that is something that I just want to bring up. I'm sure you have something in place, or other FQHCs have something in place, but because this is a podcast and people are listening, I wanted to make sure I just put that in here so that they understand that incentives do help providers take that extra step.
Good point. Dr. Melk, what are your thoughts about that?
Yeah, that's actually very timely kind of messaging. We just rolled out a new medical provider incentive plan on April 1st. So just, not even 2 weeks ago. Currently, or prior to this month, they were only being incentivized based on patient volume, so how many patients they were seeing. But beginning this month, and it's a quarterly incentive program, but there will be a multiplier or an enhanced payment of 5% if they're meeting up to 4 quality measures. So yes, so there is a financial incentive. And again, it's because our leadership believes in quality. We're not getting those dollars up front, but we want to make that investment. In addition to that, because I firmly believe it can't always just fall on the provider. Providers definitely are important to lead the team, but it is a team. Medical assistants are part of that team. Front desk who check patients in, our nurse care managers, our lab assistant, anybody that's patient facing, they also are able to share a quality incentive as a team. And we've been doing this for actually 3 years. And so our staff, our medical assistants and support staff can earn, typically it's around $250, but up to $400, depending on how well the team performed. And we have the clinic, the health centers divided up into 6 teams, and we made it kind of fun, and they get to carry the trophy if they're the best in colorectal or the best at Medicare annuals or pediatric immunizations. And so the trophy kind of, gets passed around. We definitely have been promoting quality for a long time in spite of not having, direct dollars, but taking it off of our operational budget because of how much we believe in it. But
yeah, awards and incentives always work. I have seen that personally. Too.
And that little bit of competition kind of thrown in there, it always kind of gets people, excited and having the little trophy. I think that's such a great idea to get them involved and get them thinking about not just these task-oriented approaches, but these outcome-driven approaches.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.